Good morning, ma'am. Good morning, respected faculties and dear colleagues. I'm Dr. Srikanth from the Department of Neurosurgery, and for today's session of clinical grand rounds, we're going to discuss a case about a 9-year-old child who's studying currently in fifth class, hailing from Saharanpur, and the history was given by his mother, and it was reliable. So he presented to us with complaints of restriction of neck movements for 1.5 years. It was not associated with neck pain or any click sound. He had history of recurrent falls for 6 months, following which he developed insidious onset, gradually progressive weakness of all his four limbs. It started initially in the left upper limb, and then it gradually progressed to involve the left lower limb, like numbness or tingling sensation. There was no history of bowel bladder symptoms. There was no history suggestive of cranial nerve involvement, like loss of smell, deviation of angle of mouth, hoarseness of voice. There was no any history of preceding trauma. He did not have any suggestive of tuberculosis, like fever, night sweats, evening rise of temperature, weight loss, loss of appetite. He did not have any comorbidities. Birth history was uneventful. Past surgical history, medical history, and family history, social history were not contributory. He consumes mixed diet. He was immunized appropriate for his age. He achieved all milestones appropriate for his age. He was studying in fifth class. However, he could not attend school for the last 6 months because of his illness. On general physical examination, he is conscious, oriented. There was no pallor, icterus, cyanosis, clubbing, or generalized lymphadenopathy or pedal edema. He was thin built with BMI of 13.4 kg per meter square. On examination of the spine, head was central, no webbing of neck or swelling of over the back. There was no low hairline or low set ears. There was no tenderness or deformity. There was restriction of active and passive neck movements in flexion, extension, and lateral rotation. Rest of the examination of spine did not reveal any tenderness or deformity. Neck height ratio was 11.2. Chest expansion was 3 centimeters, and single breath count was 12, and breath holding time was 8. And single breath count and breath holding time were reduced. Systemic examination of respiratory system, cardiovascular, and parabdominal examination did not reveal any significant findings. Central nervous system examination, higher mental function, MFSC score was 27 out of 30. Cranial nerve examination was within the normal limits. Examination of the motor system revealed increased tone in all four limbs, modified aspect score of 1, and there was atrophy in all four limbs. Power, there was distal predominant weakness uh, of in all four limbs. It was slightly more on the left side compared to the right side. So with hand grip of 40% on the left and 50% on the right side. And shoulder hip joints were 3 by 5 on left and 4 by 5 on the right. Wrist 2 by 5 and 1 by 5 on the left and right respectively. Ankle and AHL 2 by 5 and 1 by 5 on the left and right respectively. Deep tendon reflexes were all exaggerated. There was ankylosing on both sides. Superficial reflexes, Hoffman's was present on both sides. Plantars were extensors. Abdominal reflex and cremasteric reflex were absent. Sensory examination, there was decreased sensation of all modalities at C2 and below level of C2. There were no cerebellar signs. Gait could not be examined because he was bedridden. So, to summarize the findings of history and examination, 9-year-old male child presented with restriction of neck movements and recurrent falls for 6 months with distal predominant spastic quadriparesis and U-shaped pattern of weakness with generalized hyperreflexia with loss of pain, temperature, touch, joint position sense at C2 and below C2 without gallbladder involvement with modified neuric grade of 6. So, substrates involved were bilateral corticospinal tract, spinothalamic tract, and posterior column tracts. Based on the findings of history and examination, we had localized the pathology to cervicomedullary junction and extradural pathology because there was restriction of neck movements, and differential diagnosis given his age and slow progression of weakness, spastic quadriparesis, insidious onset, gradually progressing, and restriction of neck movements. We kept the first differential as congenital craniovertebral junction anomalies, including basilar invagination, atlanto-axial dislocation, os odontoideum, and chiari malformation. We kept the second differential as pot spine at craniovertebral junction, and neoplastic lesions as the third differential. So we had evaluated the patient with CT and MR of craniovertebral junction. So a few points about the normal anatomy of craniovertebral junction on the CT scan. So this image shows sagittal section, bone window, CT of craniovertebral junction. Few points that we will be using for the measurement of craniometric points. So A points to nasion, B points to tuberculum sella, C points to dorsum sella, D points to the anterior-most margin of foramen magnum, that is basion. E points to posterior-most margin of the foramen magnum, that is opistheon. G is the anterior arch of atlas. H is the posterior arch of atlas. I is the peg-like projection of vertebral body of axis, that is dens. J is the vertebral body of axis. And in this image, on the left side, we can see the coronal CT scan of the craniovertebral junction, bone window. On the right side, we can see the schematic diagram. So these two are the condyles of the occiput, and this is the lateral mass. These two are the lateral masses of C1 forming the facet joint with superior facets of C2, and this is the peg-like projection, that is dens, arising coming from the vertebral body of C2. So I want to draw your attention to the joint orientation of C1, C2 facet joints in the coronal plane. It is horizontal, as we will see in the subsequent slides in the atlanto-axial dislocation and basilar invagination. The orientation of the C1, C2 facet joints is changed to that of a vertical plane. So coming to the radiology of the patient, so in order to appreciate the pathology better, we had compared the index case with findings from the normal case on the left side. So normal subject. So this is a Buckingham clival canal line. This is a line drawn on the posterior surface of clivus tangential to it. So normal position of dens is below this line or just touching 1/3 of the dens. So in our case, we can see clearly that dens is projecting 1 centimeter above this line, indicating that.
Dens is same as odontoid project.
Yes, ma'am. Yes. So it is 1 centimeter above the clival canal line, indicating that there is basilar invagination. So in this slide, we can see the anterior atlantodental interval. So that is the distance between the anterior arch of atlas and the dens. So which is for a 9-year-old should be less than 3 mm. In the index case, it is 6 mm, which is almost double, indicating that there is atlanto-axial dislocation. In this slide, we can see the clival canal angle measured between two lines drawn tangential to the posterior surface of clivus, and another line drawn along the posterior surface of the dens. In normal individuals, this angle should be more than 150 degrees. In our case, it is 91 degrees, indicating that there is platybasia. And height index of class, it is measured by drawing the Vining line. That is, we draw a line from tuberculum sella to the torcula, and we draw a perpendicular line from this line to the tip of the dens. So in normal subject, it is more than 34 mm. In the index case, it is 27 mm, indicating that there is basilar invagination. So few points about the orientation of C1, C2 joint. So sagittal joint inclination, this measures the orientation of C1 C2 facet joint in sagittal plane with respect to dens. So normal should be less than 87 degrees. In the index case, it is 148 degrees, and it's significantly increased. And coronal joint inclination, inclination of C1 C2 facet joint in the coronal plane with respect to dens. So it should be less than 110 degrees. In our case, it is 142 degrees on the right side and 143 on the left side. And this parameter is also significantly increased, both pointing that the facet joint is in more of vertical orientation than in the horizontal orientation in the normal subjects. Craniocervical tilt. So this angle is measured by drawing two lines, one along the anterior surface of the clivus and another line along the anterior surface of dens. So this should be less than 75 degrees. In the index case, it is 107 degrees. This angle is also again increased, indicating that there is a basilar invagination. So we also got an MRI of the craniovertebral junction. So this shows the T2 sagittal sequence of the craniovertebral junction compared with the normal scan on the left side. The index case on the right side, we can see that the dens is projecting posteriorly, and there is significant compression of the cervical spinal cord and the junction of medulla, and there is T2 hyperintensities within the substance of the cord, and there is severe compression of the spinal cord. And again, this is the T1 sequence in the sagittal section of craniovertebral junction, showing that there is severe compression of the cervicomedullary junction, as we can see with the compared on the normal scan on the left side, and there is hypointensities within the substance of the cord, indicating that there is edema and syrinx formation. So based on the findings of the radiology and examination, we made a diagnosis of severe basilar invagination with atlanto-axial dislocation, and further management plan will be discussed by Dr. Anju.
There is no history of trauma, no?
No, ma'am. It was congenital. It may seem like a lot of parameters that we're showing, ma'am, but the idea is that the joints are deformed and they lead to the laxity of the.
But the duration of illness was only recent.
It was 6 months, ma'am.
6 months.
And neck rigidity was like deformed neck rigidity was there for 1.5 years. The quadriparesis was for 6 months.
Good morning, everyone. Before moving on to the management part, I would like to revise some of the concepts. So, basilar invagination is a condition characterized by telescoping of the odontoid process, by which what this means is there is a horizontal movement of odontoid process inside the foramen magnum, which results in the compression of a cervicomedullary junction, thereby compressing the ascending and descending tracts, which leads to severe progressive neurological deficits over the time. It may or may not be associated with the atlanto-axial dislocation. Just as a visual aid, I would like to revise the anatomy. As you can see here, in white color, this is the C1, and in brown, this is the C2, atlas and the axis. The odontoid process of the axis sits in the anterior arch of the atlas and forms a joint. And these are the articular joints of the atlas and axis. As you can see here, C1 and C2 forms the joint as the odontoid process, forming the joint with the anterior arch of the atlas. It gives a rotatory motion of the head, and the articular cartilage provides the smooth gliding of this movement. So, what happens in AAD is there is, due to laxity of the ligaments, there will be horizontal movement of the atlas over the axis, and which is the joint space, the normal anatomy of joints get disrupted, and it leads to atlanto-axial dislocation. So, coming to the management part of atlanto-axial dislocation with the basilar invagination, it will mainly depend on whether the atlanto-axial dislocation is reducible or irreducible. Reducible, when we call it a reducible AAD, when there is a reduction in the atlantodental interval after extension of the neck or providing traction. As you can see in these images, case of reducible AAD, as we can see here, in the extended position, atlantodental interval and the compression over cervicomedullary junction is reducing. So in this case, we can simply go for the posterior fixation in the extended position. Next, in case of irreducible AAD, even on extension or reduction, there will be no movement of the odontoid process, and the compression will be there even in the extended position. So in this case, we have two options. Conventionally, we have been doing transoral odontidectomy followed by posterior fixation, or we can go for the joint modification with the newer technique of DCER, which I'll be explaining in further slides. So in case of transoral odontidectomy, what we do is, by the transoral approach, we'll be opening the posterior pharyngeal wall and gain access to the odontoid process, thereby excising it and relieving the compression over cervicomedullary junction, and after that giving posterior fixation. As these conventional strategies of odontoidectomy via transoral approach and posterior fixation gives a lot of morbidity, and so a newer technique was devised whereby intraoperative manipulation involving distraction followed by compression and extension performed over a fulcrum provided by a joint spacer results in reduction DCER in both basilar invagination and AAD. As you can see in this image, this is a famous philosopher, Archimedes. He had said that give me a lever and fulcrum with which I can move the world. What he meant by that was, with the use of long lever and a fulcrum, big objects can be moved and it can make mechanical wonders. So using this concept on a smaller level, we used it in this technique. As we use spacer as a fulcrum, which results in complete correction of both AAD and VI. As the spacer is added into the joint space, it reduces the basilar invagination by providing the horizontal movement. 80% of the VI gets reduced. As we add screws, which acts as a lever and give compression, it will further, using the spacer as fulcrum, it will further reduce the VI, and providing the horizontal movement, it will reduce the AAD also. So, this is a small animation which further details the procedure. As we add spacer to the joint space, it gives a vertical movement and reduces the telescoping of the odontoid process inside the foramen magnum, thereby relieving the compression. Next, as we add the screws and using them as a lever and spacer as the fulcrum, by providing compression, there occurs the horizontal movement, which leads to correction of atlanto-axial dislocation. So this is a schematic representation as in parasagittal view. As we can see here, one is the odontoid process, two is the atlas. As there is a telescoping of the odontoid process inside the foramen magnum, and the horizontal movement of the odontoid process leading to atlanto-axial dislocation. As we add the spacer over here in the joint space, it gives a vertical movement and the telescoping reduces. After adding the screws, either occipital C2 or C1 C2, which gives a lever and giving it a compression over the spacer as using it as a fulcrum, it gives a horizontal movement, thereby reducing the AAD. So we have got both the VI and AAD corrected. So with the basic knowledge of this procedure, I would like to proceed for what we did intraoperative. Post exposure, we do is the C1 C2 joints will be explored and identified, and the end plates were drilled. As you can see here, the instrument is inside the joint space of C1 and C2, and this is the drill being used for the end plate drilling. As this is done, post drilling, we will add the spacer. In this case, we have done right-sided 50 mm spacer and left-sided 60 mm spacer. After that, occipital plate and C2 screws were fixed as the C1 posterior arch was deficient. So, with two rods and after compression, reduction was achieved. As you can see here, the occipital screws and the C2 screws, adding the rods and giving the compression will reduce the AAD. After that, bone graft was used. Fusion was done using the iliac crest bone graft. And lastly, foramen magnum decompression was done. In this, what we do is remove the a small part of the foramen magnum, the bony part of the foramen magnum, to relieve the compression from the posterior aspect. And as the C1 posterior arch was deficient, it was, but a small part was there on the posterior aspect that was also removed. This I apologize for the poor quality of this image, but this is the intra-op image of the procedure. As we can see here, these are the spaces into the joint spaces and the screws, rod, and after that compression was done, reduction was achieved. So this is the final construct. Here we can see the occipital plate with the screws. These are the C2 screws, rods, bending in the anatomical position, and the spaces cannot be seen here as they are lied deep into the joint. So post-operative course, the patient was shifted to ICU on ventilator support. In view of need for prolonged mechanical ventilation, tracheostomy was done. His condition gradually improved and was weaned off from ventilator. Decannulation of tracheostomy was done on post-op day 17. His neurological status gradually improved and he was discharged in satisfactory condition on post-op day 24. At the time of discharge, patient's condition, he is conscious, oriented, following commands, afebrile, accepting orally, ambulating in wheelchair, and modified neuric grade was 5. So these are the post-op images. To explain this, I would like to call Dr. Srikanth.
So we got the post-op CT scan done 6 months after the surgery. So
What was the post-operative status, functional status of the patient, say 1 month? This is 6 months after.
yes, ma'am. That is
So
we
what
will be
was the status, may say 1 or 2 months post-surgery?
that we are describing after this imaging. So
At discharge, he was Neuric 5, ma'am. At presentation, he had started with Neuric 6. He was like totally dependent. And at discharge, he was like just about to get better. And then he will show us subsequently.
Started his hand and feet.
Yes, ma'am. He was already moving, ma'am, but it was like quadriparetic. Not plegic, but quadriparetic, ma'am. So power was like 4 to 2/5 in various joints.
उसकी recent कुछ है 20 के बाद से.
Yes, ma'am. We have like, actually, the patient came for follow up and has been sending us videos. That's how we thought of presenting this.
Okay.
So we got the post-op CT scan 6 months after the surgery, and to compare the preoperative parameters, so we can see on the left side the anterior atlantodental interval was 6 mm, and in the post-op scan it had reduced to 2.78 mm, that is within the normal limits. And the joint parameters had also improved significantly. Sagittal joint inclination improved from a pre-op value of 148 to post-op value of 122, and the coronal joint inclination also improved from a pre-op value of 142 to 110 on the left side and 139 on the right side. And the craniocervical tilt also improved from the pre-op value of 107 to a post-op value of 62 degrees. So the MRI scan in the post-op period, so it's on the right side. Compared with the pre-op scan on the left, we can see that there is decompression of the cervicomedullary junction and the T2 hyperintensities within the cord substance serines. They have resolved significantly. It has improved in the post-op scan, and we have achieved full reduction of the atlanto-axial dislocation and the decompression of the neural elements. So these are the follow-up videos that his parents were more than delighted to share with us. Him doing running, climbing trees, school cycling on his own, among other things. So at fifth month of after surgery, he started walking on his own without any assistance. So these are the videos at 1 year post surgery. So he had improved to from a neuro grade of 6 to 0 at 1 year of follow up. So functional outcome in the pre-op period, he was not able to attend school or play with his peers. He was bedridden at the time of presentation to us, and he was dependent by his activities of daily living. So in the post-op at 1 year follow-up period, he is fully independent, able to attend school. He cycles to school on his own, and he had improved from a modified unit grade of 6 in the pre-op period to post-op at 1 year to 0. So take-home message from this session is that the newer technique, distractive, compressive, extensive reduction, has several key advantages over the traditional approaches in that the newer technique aims at restoration of the physiological joint anatomy by correcting the deformity, and it uses spacer not only to provide distraction but also as a fulcrum for enhanced reduction, and it achieves better biomechanical long-term stability by fusing the single level spinal motion segment, and it achieves reduction of both basilar invagination and atlanto-axial dislocation by intraoperative manipulation of C1 C2 facet joints in the same sitting, that is in one procedure. So it avoids very morbid transoral procedure, second surgery. So these are the cases that we had done over the last few years, and these are the references. Thank you for your time, and now the call is open for discussion.
Ma'am, that's titanium.
Right.
Like we use titanium implants for most of our spine procedures, so that is what it is. You can come and join here, Shrikant. So thank you, Shrikant, and thank you, Anju, for that presentation. So to sum up the whole presentation, basically the patient was a case of basilar invagination and atlanto-axial dislocation, where the dens actually telescopes up and compresses the cervicometal junction, thereby causing severe symptoms of quadriparesis. And like the patient also had short breath holding time and decreased respiratory function, as breath holding time was less and single breath holding time was also less. So this patient, we evaluated the patient and found out that patient had basilar invagination along with AAD, and we corrected the procedure by doing DCER technique. Traditionally, what people used to do was that they used to like go transorally and decompress the spinal cord by removing the odontoid, which was compressing the spinal cord, and they used to fix the spine in the same deformed position without correcting the joints at all. But over the years, like people have devised this technique of DCR. Like it went a like long progression, which we did not show, but it took about 2 decades of all these changes that people have now started manipulating the joints. They correct the joint deformity and correct the deformity so that the spine gets corrected in its actual how it is supposed to be, that shape, and then we fix the spine in that position. So that is the whole idea of doing this procedure. Like we try to show it as much as we could. I hope we could send the message across. Any questions from the house?
So that was the video of improvement which you showed
Yes,
after 1 year of post-operative period.
Ma'am, these videos were like sent over the last video was actually very recent.
What is the recent?
The last video was very recent, yesterday only.
Okay.
The cycling video was.
Is recent. Excellent.
Thank you, ma'am.
And what about all these spacers, etc.? They will remain there.
They will remain there, ma'am. We don't touch them again. In fact, for all the spine procedures, we never take out the implants. Orthopedicians sometimes remove the implants for like limb fractures and all, but for spine we never do that. Even they won't do that, ma'am.
So we have to make a few comments.
So first of all, congratulations to the department for conducting this particular surgery, especially Dr. Anju. I think she has been the operating surgeon, and with Dr. Nishant. and
Ma'am.
others. So I believe this is surgery which has been recently kind of this technique of DICER has evolved, and it is giving, at least in this patient, has really given a very good result. So my question is, first is my observation that when we are demonstrating this kind of procedures, I was just thinking how difficult it is to demonstrate to a sitting audience what is actually happening
Yes, ma'am.
inside the operating room and how you are actually doing this particular procedure for the students to learn who are observing you. So maybe you can construct something in a three-dimensional view. I mean, you've already shown some videos, but maybe some three-dimensional structural view which can be shown for this particular thing. I'll have to take this call.
Hello.
Do we have any other questions from the house? Or any comments? Roorkee. Okay. So,
MH Rookie.
MH Roorkee, are you there? Do you have any questions?
Sir, morning, sir.
Yes, good morning.
First of all, I would like to congratulate for the effort yesterday that you have put in, sir. It's really a nice surgery.
Thank you, sir.
One or two questions from the side. First is there a possibility during the birth of that particular child, some manipulations, some issues have been happening place, which has resulted in such severe dislocation?
Oh, yes.
That is the first one.
Okay. Do you have any other questions or should I answer that one first?
I'll ask you once the answer is done.
Right, sir. So this is actually a congenital deformity which happens because of laxity of joints and deformed, bony deformations. So it is like, it sounds that it can happen, but it does not happen with at the time of birth. It is like there congenitally.
And what is the reason for presenting so late? If it had been present in maybe a congenital.
Why?
So-
So the patient had a neck deformity, but had started having quadriparesis for the last 6 months. So they showed around. They went to doctors in Saharanpur, their nearby area, and eventually went to a neurosurgeon who referred the patient to us. So that is why they took time to present. But for the first 8 years, they did not have like very severe symptoms. So they like the child was functional. He was going to school. They did not feel the need to show anyone.
Right. The second thing is regarding the ambulation which you have discussed.
Yes.
The linear ambulation respect to axis on the either side. Like connected to it from one to three, which is on the left side to right. And on the right side it has to 130 from 140, which is insignificant compared to the left side. But still, people had excellent functional outcome. So does it have an effect on its neurological states?
No, it is not always possible to use a spacer to correct the joint, like the joints in a normal position. So whatever result we get, we take that. And the MRI shows very good decompression of the spinal cord at the cervicomedullary junction. So that is the most important thing for us, that we should be able to decompress the neural tissues. And we don't want to like go in again or try to just correct the CT scan finding.
Got it. Thank you.
Thank you. Thank you for the questions. Do we have any other questions? Yes, please. Dr. Kavindra. You can come here and.
So my question is, what are your thoughts on doing C1, C2 fixation for this case? Because biomechanically it is the most stable construct that you can give to the patient rather than occipitocervical. So what are your thoughts on this?
Yeah, that's a very important question. Actually, we did not show that here, but we tried to put the C1 screws first, and the lateral mass broke. So that is why we had to go for the occiput to C2 screw. But yeah, C1, C2 was our first choice. And for the audience, yes,
Can I
ma'am.
go with my comment?
Yes, ma'am, please.
So one was about how to teach the students about such complicated procedures. So since we have the skills lab and you would be able to create some of these like a spinal cord, the spine structure, and then you can probably physically show it how this happens, because that was something which was very interesting and maybe difficult to demonstrate. So a job very well done, and such a beautiful functional status restoration which has happened in this particular child. I think the family must be really thankful to the surgeons. We know that atlanto-axial dislocation is not very uncommon.
Yes,
It is. I really want to know the figures, if we know, as to how common it is. And this can be congenital. It can even be traumatic because of all
This
the
is not the
accidents and
question
everything.
absolutely asked.
So once it has happened and you have delineated what it is, so I know the outcome may be different in different kind of etiologies.
Yes, ma'am.
And the procedures also may need to be modified a little bit, because these acquired lesions, the ones which are there after trauma, they can, I think anything can happen in
Yes,
those
ma'am.
situations. So I think for public teaching, so now that, we have a facility, which has corrected it, and I think we should be able to use it for public education. So if we can bring it out as to how common it is and how well it can be done, because you can probably write a story for this, that how this child has improved, how he was before the surgery, and how he is now, say after 6 months to 1
Yes,
year after the surgery. So for that, I think we'll need some epidemiological kind of information and the clinical outcomes, which you have shown that you have done so many cases, and whatever the results have been in all those patients. I'm sure you must have published a series of these cases which have been there.
No, ma'am.
If not, I think.
Not this one, ma'am, because this is more common than what we see here. In fact, Dr. Kavinder only operated 2 cases this week only.
Okay, so
or
it
last
is
week.
something which you can
Which
become
is-
like a referral center
Yes, ma'am.
for this type of surgeries, because we know that all surgeons need to become specialists in
Yes,
one
ma'am.
particular field. So this is something which is very gratifying, I think,
Yes,
for
ma'am.
at least for this patient. Thank you.
Thank you for your comments, ma'am. Just to answer this thing, that we somehow don't see as many cases as we would like to see. Sometimes there's a splurge of lot of cases that we see, and sometimes there are not so many. But it is fairly common, so as to say. So just publishing these 30 odd cases will not get us a publication. But just to show that we had done this procedure where, and it, like you said, it needs to have a proper flowchart as to when to do what. Like traumatic cases have a different management. So if it is traumatic, we can also put an odontoid screw, ma'am, through the fractured segment of odontoid, or we can do postfixation in the reduced position. And this DCER procedure is only used for congenital procedures where we have to correct the deformity of the joints. And sometimes we don't even need to do DCER. Like a lot of cases where we did, it was just fixation in the C1, C2 reduced position, like how Dr. Anju showed that if it is reducible AAD, then we can just fix it in that position without having to do anything with the joints.
Are these cases are going to orthopedics also?
Ma'am, yes, ma'am, they may be doing a few cases, but very complicated cases they refer to us for C1, C2 because it involves recommended junction and they don't want to touch those cases.
Is there any new technology? We are going for certain new iOS and all those things. Are they helpful in this kind of surgeries or? Is there any new technology, radiologically or intraoperative radiology or MRI? Is that helpful in, better
Yes, ma'am.
results or easy surgery for this?
Ma'am, we can use neuronavigation sometimes to see where we are, but mostly this is very anatomical based, ma'am, so we know where to go. The challenging part here is that where we go into the joints, it is very close to the vertebral artery and the vertebral plexus. So that is when it bleeds, and neuronavigation will not be able to help us with that. It can just tell us where we.
This is done with an operative microscope or
Yes, ma'am.
direct?
With the operating microscope and a C-arm,
Okay.
like an intraoperative X-ray, ma'am.
Okay.
Thank you.
Thank you very much. Yeah.
So we close the session with that.
Yeah.
Thank you very much for attending the session. Thank you.